Hello everyone, welcome to Radiology cases tutorial. Today we are going to discuss the malignant renal neoplasms. In this video, we will discuss the renal cell carcinoma, urothelial cell carcinoma, and lymphoma. Let's start now. Renal cell carcinoma is most often a solid mass that is slightly more echogenic than the adjacent renal cortex. However, it ranges in the echogenicity from very hyperechoic to hypoechoic. About 50% of the renal cell carcinomas are hyperechoic as compared with the normal adjacent renal parenchyma. Now in this sonogram, we can see that this is the hyperechoic renal cell mass with well-defined margins, and its echogenicity is more than the renal cortex. This is the renal cortex that is looking hypoechoic, then this is renal cell carcinoma. Now, in this sonogram, we can see a very echogenic mass that could simulate angiomyolipoma, but it has well-defined margins and its echogenicity is very greater than the renal cortex. And on MRI with contrast, it was proved that it is the renal cell carcinoma. About 30% of the renal cancers are isoechoic to the renal parenchyma, and in this sonogram we can see that this is the longitudinal gray scale and this one is the power Doppler view. It shows the isoechoic mass with very ill-defined margins, and it is very difficult to visualize on the gray scale, but it has the abnormal internal vascularity that is visible on this Doppler. About 10% of the renal cell carcinomas are hypoechoic to the renal parenchyma, and in this sonogram we can see a longitudinal view that shows a hypoechoic mass that is arising from the lower pole of the kidney, and it has well defined margins and its echogenicity is less than the renal cortex. And this one is the longitudinal view. It shows a hypoechoic mass that is arising in the central renal cortex. This one is the upper pole of the kidney and this one is the lower pole of the kidney. This one is the hypoechoic renal cell carcinoma with the well-defined margins. Many renal cell cancers will be complex, either solid with scattered cystic components or the solid with hemorrhagic or the necrotic regions. Now in this sonogram, we can see a complex renal cell carcinoma. This is the longitudinal view of the kidney. This is the upper pole of the kidney and this is the lower pole of the kidney. And we can see a predominantly solid hyperechoic mass with scattered cystic components, and it has poorly defined margins. This is a sonogram which is showing the longitudinal view, and it shows a very large mass with well-defined margins, and it is occupying most of the upper pole of the kidney, and it has the central areas of liquefaction. It may be due to hemorrhage or the necrosis. About 20% of the renal cell cancers contain identifiable calcification that may appear punctate, amorphous, or the mottled. And in this sonogram, we can see a renal cell carcinoma with calcification. This is the longitudinal view of the kidney, and it shows a solid mass with punctate areas of the central shadowing calcifications. These are the internal calcifications, which is also showing the acoustic shadowing, and it has also partially defined margins. And this is another longitudinal view that shows a large mass with the solid cystic components as well as discrete shadowing calcifications, which showing the acoustic enhancement prominently. Although it is not uncommon for the renal cell carcinoma to contain the cystic components and areas of necrosis or the hemorrhage, predominantly cystic renal cell carcinomas are unusual and account for less than about 5% of the total cases, and they may be assumed form of a cyst with multiple thick septations, a thick or the irregular wall, or a cyst with solid mural nodule. In general, the likelihood of malignancy increases with increasing number and the thickness of the septations with increased wall thickness or irregularity. Now in the sonogram, we can see a cystic renal cell carcinoma. This is the longitudinal view of the kidney, and it shows a mass in the upper pole that is consisting of multiple small internal cystic elements. These hypoechoic areas are the cystic elements, and hyperechoic structures are the internal septations. And in the sonogram, we can see a large cyst with septations and irregular internal solid element. Detection of the blood flow within the solid appearing areas of the complex cystic lesions should be taken as a strong evidence of malignancy. And here we can see a cystic renal cell cancer with vascularized mural nodule. This is the transverse view that shows a large cyst with low level internal echoes and a solid echogenic round mural nodule. This is the sonogram of power or the pulse Doppler view that shows the internal blood flow with arterial signal, and this excludes a cyst with hemorrhage from the differential diagnosis. Renal cell carcinoma is a vascular tumor and has many instances. It is possible to detect the tumor vascularity on the color of the power Doppler. For indeterminate lesions, detection of the vascularity is helpful because it indicates that the lesion contains the soft tissue and is almost certainly a tumor. And here we can see the vascularity in the renal cell carcinoma. This one is the gray scale and this one is the power Doppler view, and it shows a very hypoechoic solid mass that is simulating a cyst, but it does not have prominent acoustic enhancement. That is the property of a cyst. And the readily detectable internal vascularity indicates that it is a tumor, and surgical pathology confirmed a renal cell carcinoma. Now we'll discuss the staging system for the renal cell carcinoma. The most widely used staging system for the renal cell carcinoma is the Robson system. The stage 1 is confined to the kidney, stage 2 is invasion of the perinephric fat, and stage 3A is invasion of the renal vein, stage 3B is regional nodal metastasis, and stage 3C is combined venous and the nodal involvement. And the stage 4 is invasion of the adjacent organs, which is the stage 4A, or the distant metastasis is stage 4B. Now we are going to discuss the renal vein invasion in the different patients. This is the transverse view, and this one is the power Doppler view. It shows a mass in the right kidney and a tumor thrombus in the renal vein. This one is the renal vein, and in this power Doppler we can see tumor vascularity within the thrombus. Now we are going to discuss another renal malignant neoplasm, that is the urothelial cell carcinoma. It is usually occult sonographically, and when seen, it is typically located in the renal collecting system or the renal sinuses. The sonographic appearances of more bulky urothelial cell carcinoma includes the intraluminal polypoid mass, thickening of the urothelium, and an otherwise non-specific solid mass centered in the renal sinus. This is a longitudinal view that shows the hydronephrosis, and it shows a solid mass that is centered in the upper pole of the collecting system. And this one is the transverse view. It shows hydronephrosis and focal thickening of renal pelvis that is visualized here, and it has less echogenicity than the surrounding areas. This focal thickening is the urothelial cell carcinoma. One potential pitfall in the diagnosis of the urothelial cell carcinoma is mistaking prominent renal papillae as a filling defect in the calyces. This can occur in the setting of the hydronephrosis. The primary distinguishing feature of the papillae is that they appear in all the calyxes, but other lesions such as the urothelial cell carcinoma appear only in one or very limited number of calyxes. Now here we can see the prominent papillae tips, and this is the longitudinal view. It shows the moderate hydronephrosis and distension of the calyxes, and the tips of the papillae are seen protruding into the calyxes. And this one is the oblique view. It shows the papillary tips that are appearing to be isolated solid lesions within the lumen of the calyxes, and these should not be confused with the tumor, blood clots, or other filling defects. Now we are going to discuss another renal malignant neoplasm, that is the lymphoma. Lymphoma and the metastatic diseases usually involve in the kidney in a multifocal manner and can be very difficult to detect sonographically. Lymphoma is usually very hypoechoic and on rare occasion may mimic a renal cyst. In most cases, the lack of acoustic enhancement deep to the mass provides a clue that it is a solid and not the cystic. Now, in the sonogram, we can see the longitudinal view that shows the several hypoechoic areas with little stromal tissues, and there are the few internal reflectors, and this is the result of an anechoic or the near anechoic appearance that simulates a cyst in the kidney, but it does not show any prominent acoustic enhancement. That is the clue that these are not the cystic, but these are the lymphomas. And the same as the case here, it shows scattered, small, poorly marginated areas that are submasses in the renal cortex. Now we are going to discuss the perinephric lymphoma. The one fairly characteristic pattern of the lymphoma is the involvement of the perinephric space, and this can be vary from small areas of the perinephric infiltration to the extensive encasement of the kidney. The perinephric involvement is typically anechoic or very hypoechoic, but a minority of the cases are mixed echogenicity. This is the oblique view. It shows a septated cyst in the kidney that has internal thick septa and a very hypoechoic tissue in the perinephric space. And this is the longitudinal view that shows the hypoechoic to anechoic infiltration of the perinephric space around the upper pole of the left kidney. And this is the upper pole of the kidney that is adjacent to the spleen. In both cases, the lymphomatous infiltration of the perinephric space could be confused with the perinephric fluid, but these are the characteristics of the lymphoma that is simulating the perinephric fluid.